I think it's really important as clinicians to start out by asking the question, does this person have known prior cardiovascular disease or not?
Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, as always, it's a pleasure to have my co-hosts with me today, are Dr. Arjun Ghosh and Dr. Daniel Lenihan. I wonder if each of you could just say hello, introduce yourself, tell us where you are. Arjun?
Thanks so much, Steve. I'm a consultant cardiologist at Bart's Heart Centre and University College London Hospital, and I run the Cardio-Oncology service at UCLH.
Great. Always good to have you. And Dan?
Thank you very much, Steve. I'm a founder and board member of ICOS and am a cardio-oncologist at St. Francis Healthcare in Cape Girardeau in Missouri in the United States.
Great. Always good to have you as well. And it's a privilege for us today to welcome two guests who have really broad experience and expertise in research in the field of cardio-oncology. So I first want to introduce Dr. Darryl Leong. He's Associate Professor of Medicine and the Director of the McMaster University and Hamilton Health Sciences Cardio-Oncology Program. And he is the chair of the ICOS Research Working Group. So welcome, Darryl.
Thanks very much, Steve. It's a pleasure to be with you. Thanks for the invitation.
And Dr. Tia Higano, she is Associate Professor, Adjunct Professor in the Department of Urologic Sciences at the University of British Columbia. So Tia, welcome.
Yes, thank you. Looking forward to our discussion.
Well, as always, we like to have our guests just tell us a little bit about your own professional background and particularly sort of how you ended up with an interest in the field of cardio-oncology. So maybe, Tia, you could start.
Sure. So I'm primarily focusing in prostate cancer as a GU medical oncologist. I've been doing it for a long time. So some of my earlier interests in cardio-oncology date back to the old days of anthracyclines, when anthracyclines were some of the only drugs that we had to treat various cancers. But over time, my focus in prostate cancer brought me to trying to understand, whether there were differences between LHRH agonists and LHRH antagonists. And to that end, I was part of the PRONOUNCE trial, which was reported out last year. So I also sort of think I'm an early adopter. And this is a really new and growing and exciting field. And so I think actually you might laugh at this, Dan, but I was talking to Mike Ewer this morning about just the whole field, because he and I go back on a paper from a long time ago. But I've had some interesting connections in the field that are just by coincidence.
That's fascinating. Yeah, no, as I'm sure you probably discussed, I worked with Mike for 8 years at MD Anderson about a decade ago. And he's been pursuing the whole anthracycline piece for quite some time, as I'm sure you know. So
yes, I do.
That's great. Well, it's great to have you with us. Thanks for giving us your time today. And Darryl, tell us a little bit about your background and how you ended up with an interest in cardio-oncology.
Sure, Steve. So my background methodologically is really clinical epidemiology and clinical trials. And one of the things we've been observing is that, cardiovascular mortality rates globally are decreasing, which is terrific. And that's really a testament to a lot of the folks that have done research in cardiovascular diseases. But one of the consequences of that is that we notice that cancer mortality as a proportion of all deaths is actually higher in many settings now than cardiovascular disease. So that's one really good reason to be interested in cancer outcomes. But of course, huge progress has been made by folks like Tia in cancer research as well. And so we're seeing this kind of complex relationship where cancer deaths are also on the decrease for many different cancer sites. And so our patients now are really living with both cardiovascular disease and cancer as chronic diseases. And that's why I think it's really important that we understand how the two interact with each other and the treatments interact, and we develop strategies for helping patients with what is really an evolving field and a new way of living with these chronic diseases.
ESC and ICOS were also obviously co-authors in those guidelines on cardio-oncology. And there was quite a large section on prostate, urological cancers, and androgen deprivation therapy and these issues. So maybe if I could start with you, Darryl, and then come to you, Tia, as to what you thought about the guidelines, and then specifically focusing on your areas of expertise and what was missing or what needed to be added, or whether they were fully comprehensive. Darryl, if I could start with you for your thoughts.
Yeah, thanks for the question, Arjun. Look, I think there are a tremendous body of work, and we were talking a little informally before, but as Tia said, a terrific resource for healthcare practitioners at various levels. So a huge amount of work has gone into what is a really sizable document. I think where I have some mixed feelings, I guess, is that there are a large number of recommendations that have been made, and I do think the context is that this is a relatively new specialty. And perhaps the evidence to support some of these recommendations might not be so strong as we would like to see for them to be solid class 1 recommendations. We see examples of this all the time. For instance, I was on a call with a colleague earlier today proposing a randomized controlled trial where we felt there was certainly clinical equipoise. We see that, talking to clinicians around the world and patients as well. But the current guidelines endorse a particular course of action, albeit on a total sample size research of N equals 50. And this was a non-randomized study. So to have a firm recommendation that clinicians are following on 50 patient experience, to me, is just, it's not robust enough. And so that's where my hesitancy with some of the recommendations would lie.
Okay, that's very interesting. And Tia, from your point of view, from the oncologist point of view, do you think the guidelines can reach the oncologists, or should they be, what should the oncologist take home from the guidelines?
Yeah, I think. Well, I echo what Darryl said. I think that the guideline as a whole is a beautiful compilation of information. I think when you go into, for example, an area that I know well, prostate cancer and androgen deprivation therapy, you might see some of the oncologic holes in the guideline. For example, if you look at figure 21, it's really hard, I think, to understand that we don't use a lot of these drugs in the table alone. We use them in combination with standard approaches to androgen deprivation therapy. But you could be a little misled by that figure, I think. And oncologists also have to think of this because we're with some of these drugs that are in that table. Just for example, the second generation anti-androgens. There's a very strong signal for hypertension, for example, and in 2 of the 3 drugs. And we need to understand that there are differences. They're all 3 second generation anti-androgens, and in fact, from the cancer standpoint, they have similar efficacies, although I'm throwing that out from large phase 3 trials. They haven't been studied head to head as far as efficacy. But the toxicity is on top of standard ADT when you add these drugs. So that's one thing. I think another thing that I think is important, and I think this came out in the guideline. I don't know. I did so much reading in the last 24 hours, I might be confused. But I think it's really important as clinicians to start out by asking the question, does this person have known prior cardiovascular disease or not? like Darryl said, not all of these recommendations, or actually probably most of the recommendations, aren't based on, level 1 evidence. And we have to take into account the risk benefit. I mean, sure, a drug could have some cardiotoxicity, but, I've had patients actually say, oh, they don't want to have ADT because of potential cardiotoxicity. And you're there, oh, no. This is, it's so, yes, there's something there, but no, that's not something you should not take because of that small. So it's, I think that is something in the guideline that I think they try to address that, but I think it's challenging.
Sure. I mean, maybe if I could just ask another question on the guideline before handing over to Dan, but if I could just bring your attention to recommendation table 16, and for the listeners, not everybody maybe has memorized every table and every number, but maybe if I could just explain. So this is the recommendations for baseline risk assessment and monitoring during androgen deprivation therapy for prostate cancer. And T, as you mentioned, they do talk about the baseline cardiovascular risk assessment and using an established, risk score and ECGs and looking for QT prolongation. So I just wanted, from your point of view as an oncologist, do you think this is reasonable, doable, and who's going to actually implement this, and who's going to follow these patients up, for example?
Yeah, I mean, I think this is a really important question, and I mean, one of the things in that table includes use of a screening device called SCORE2 or SCORE2 OP, and I mean, from what I can see, that those are European screening questions, so I'm not really sure how that will apply to North American patients, but I don't think that kind of screening is real. I mean, I think it's just as easy for a clinician to determine from a history from a patient whether or not they've had prior cardiovascular disease. I don't know if you have to go through all the rest of that.
Okay,
but it's pretty inclusive. I mean, there's nothing. I don't think there's anything left to the imagination there.
Right. And Darryl, from the cardiologist's point of view, what would you say about table 16? And how easy would it be for will it be the oncologist or the primary care provider? Because as Tia mentioned, no matter what score you use, you can use a Framingham risk score, or in the UK you can use a JBS score. But it is work, and it's not necessarily intuitive to a non-cardiologist.
Yeah, this is a real big issue, because while in principle, we'd certainly agree that everybody probably of this kind of age should have their cardiovascular risk looked into. I think many urologists, uro-oncologists may struggle for the time capacity to do this in busy settings. They may suffer from lack of familiarity. I've received feedback about, I don't know what to do about cholesterol levels. And I actually know urologists who don't have a blood pressure cuff in their office because it's not part of their core business and their core, what they deliver to patients. Equally, when you talk about family physicians, we have data in a paper coming out in JACC Cardio-Oncology soon to show that about 75% of men with prostate cancer, in a large cohort, so nearly 3,000 people, their blood pressure does not achieve what the guidelines suggest as target. And 50% don't have cholesterol levels, LDL levels, that are at target according to guidelines, suggesting that at a primary care level, there's a big gap there as well. Can cardiologists fill that role? Look, I'd like to think so, but there's a heck of a lot of patients out there, and it may be difficult for many cardiologists to accommodate these patients, on top of their busy practices. So I think we need to start to think about some innovative strategies to deliver the care and the risk stratification that these patients need.
Great, thank you. I think sorry.
Oh, I just wanted to add to that about the primary care physicians. I also think that from their standpoint, they develop a reluctance to be that involved with a cancer patient once they're seeing an oncologist, because, they figure they're already seeing another doctor. The blood pressure, whatever, isn't as important as the fact they have this cancer that needs to be treated. And so they kind of hand over everything to the oncologist, commonly, not always.
Yeah, no, I think that's a very, very common point, and a very important point as well. So a lot of communication, I think, between cardiologists, oncologists, and primary care is a common theme always in our cardio-oncology discussions, I think. Well, thank you for your perspectives from the oncology and cardiology point of view on the recent guidelines. I'll maybe hand over to Dr. Lenihan for his questions and thoughts.
Yeah, thanks, Arjun. Tia, you said a couple of things that are kind of like my favorite topics to jump on, and what it really is that, you know, your perspective of, you know, a table that outlines all of these cardiovascular manifestations of some prostate cancer drugs, you know, and then you look at the table and you see there's all these big circles and smaller circles. And in the end, you know, it's pretty common that somebody may have hypertension or some establishment of coronary artery disease during the course of cancer treatment, just in general. So I mean, the fact that there's a high rate of those adverse events is not trying to, at least not so much, it doesn't come through in the guidelines, but certainly in our conversations or in our interactions with other providers, you know, it's not about whether or not these drugs have adverse events, because every single drug has tons of adverse events if you really tabulate them all. Mm-hmm. But it's more, okay, these are the issues that we need to get ahead of. And we want the patient to get the best cancer therapy. And, you know, that doesn't mean no therapy. It means you pick the best therapy, whatever you think it is. And we need to do a better job about managing the hypertension or hyperlipidemia or complications of cardiovascular disease that may occur. We need to get on top of that. And, you know, as you mentioned offline about Dr. Ewer, you know, one of our first major conversations as time was going on was about, you know, people would get Herceptin and they would show some change in LV function, and then automatically the patient was taken off Herceptin forever. And, you know, what a tragedy that is, yes. Especially because, you know, the drug is so important from a cancer point of view. And as it turned out, definitely we felt like we could manage those problems. So in the end, now people give Herceptin, and, you know, some people might even argue they don't even monitor for cardiotoxicity much anymore because it's so safe, because, you know, we're sort of paying attention. Yeah. But I think that's the concept. It's not to say that a drug is bad, but rather to say, okay, these are the issues, we need to manage them. And, you know, so if the guidelines seem like they're saying, oh, there's all these cardiovascular problems, that's not really the main intent. The main intent is to say, okay, as cardiologists, we need to do a better job dealing with these problems so that people get their best cancer therapy, as long as it's, you know, still working. So I think that's a real strong message that we need to make sure gets out there about, you know, not only these guidelines, but just what we do in general. So yeah. I think that we really want to hear from the oncology side to make sure that we're delivering the right message.
Yeah, I think that, you know, medical oncologists in general, maybe, I mean, sort of like cardiologists in general, haven't necessarily been focused on the other side. And I think that, you know, with all these new drugs we have now, with a variety of these toxicities, like all drugs have, but I mean, and now that patients are living longer, it makes a big difference how we think about the cardiac issues, especially since that could be the number one cause of death that's non-cancer related, at least in prostate cancer. So, you know, I just think we have to have a measured perspective when it comes to guidelines like this. I think we still have to be clinicians and Perhaps, you were saying, well, do you need to monitor, after Herceptin, or can you just figure out based on physical exam and history, does the person have any sign of heart failure? I mean, do we really need to get a teeny weeny difference on a MUGA scan or something? So I hope that the field of cardio-oncology doesn't swing so far in the procedural, aspects that will raise concern from the oncologists and cause people not to use drugs that are really important for longevity.
Yeah, I sincerely hope not, and I can assure you that I will not allow that to happen without a fight. So,
good.
But Darryl, I don't know. Tia mentioned about the PRONOUNCE trial, and I'm pretty sure you were involved in that too. And you can look at the PRONOUNCE trial there's at least two major ways that you can look at it. And I think I've sort of chosen one way, but the sort of party line observation of the PRONOUNCE trial was that that there wasn't a demonstrable difference between agonists and antagonists in terms of treatment of prostate cancer, at least as it relates to cardiovascular events. So that's sort of the summary statement. Do you agree with that?
Not entirely, Dan. And the reason is that, the trial, because of a number of circumstances, just was underpowered. So that neutrality in the top line result comes because there were 25 outcome events at the end of the study, I think, in total. And, I've had folks say to me, well, it was a neutral study, but I put it this way. If there had been two outcome events, one in each arm, because it was a very short, brief trial, would that be enough to say that there was neutrality and there's clear evidence that one drug is the same as the other for cardiovascular events? And, I think most people would say, no, the answer is no, we just don't have enough. So the question then is, well, where do you draw the line? Is it 4 outcome events? Is it 6? Is it 25? Well, that's where the powering of the study comes in and the upfront statistical calculations. And that would suggest that we need quite a number more outcome events to be able to show if one drug is better than another. Now, there have been arguments that, look, you would need a very large trial, perhaps a prohibitively large trial, to be able to demonstrate a small benefit of antagonists over agonists. And sure, there are practical considerations like that and feasibility considerations. But at the end of the day, the science, in my mind, has got to try to come first and got to try to win with the science. And if there's any way we can demonstrate with a large enough and robust enough study that antagonists are better or not than the agonists for cardiovascular events, that would be a huge breakthrough, not just for prostate cancer, but for cardiology, because it changes the way in which we think about, cardiovascular disease as well. It's a new paradigm.
Yeah, and Tia, I wasn't trying to cut you off there, but there is another view, or at least I certainly have another view of the PRONOUNCE study. When you look at the therapy that was given for those patients from a cardiovascular point of view, it was very high in terms of statin use and also antiplatelet therapy. Very high. I think it was over 85%, maybe even over 90%. So these are all patients that were seen by cardiology and managed their cardiovascular issues because they all had established coronary disease.
Correct.
So that is one of the reasons why I would say there was a very low rate of events. Yes, because cardiologists were involved and they did their part of the
right.
story.
And that's exactly. I actually brought this up early in the discussions of trying to understand the results. But in conjunction with that, the other thing to realize is if you recall that the trial was powered off of numbers from the Albertson study that, put together 6 phase 3 trials and looked at outcomes in agonists versus agonists. I mean, those patients were clearly 10 or more years behind in where we were with therapies for underlying cardiovascular disease. And so, in retrospect, it was a big mistake to use that to power a study that was now, 15 years after those patients had been treated, because the advances in cardiovascular medicine, sorry about the dog, the advances, have made a big impact, I think, on cardiovascular outcomes.
And I think, I think it's not only that, but the fact that the patients were on those medicines, that they weren't, new diagnosis of prostate cancer that hadn't had any assessment of their cardiovascular risk factors. They were well characterized patients that were on optimal medical therapy,
right,
for their heart disease.
Part of the requirements on the trial for all these men coming into the trial with known cardiovascular disease, the requirement was that they had to be under the care of a cardiologist who was going to be participating, with the care of this patient during the trial, because there was some concern. I mean, one of the reasons that was done is there was some concern that maybe this could be accused of being an unethical trial, because, we supposedly already knew that antagonists were safer for these men than agonists. So everybody wanted to make sure that the patients had optimal, cardiac care. Yeah,
I think that really probably drove down the rates of adverse events. So to Darryl's point, that you would have had to do some huge study to show a difference. If there is a difference, it would have taken a lot more patients, because their risk factors were well managed. And, that's just not reality. I mean, of the people that I see right now that have prostate cancer, most of them have been treated for a while, or they already had their surgery or their radiation or something like that. Mm-hmm. And, they're way down the line, and they haven't even had a lipid panel, or their blood pressure wasn't measured. It wasn't part of the picture.
Well, and that's where I think, just even having guidelines about cardio-oncology now is important, just as a reminder, like, we have to think of these things. Just because a patient had cancer doesn't mean we don't pay attention to their cardiovascular risk factor and take care of them. I mean, if they have hyperlipidemia and they're not on a statin, there's something wrong.
Yeah, I mean, at least in the United States, for sure.
Yeah.
If you get into your 70s and if you're not on a statin and aspirin and all that, then you're partly a unicorn. But the Darryl, so where do you think we need to go from here? With the PRONOUNCE study, and I know you're working on some pretty big studies. So can you tell us about those things?
Yeah, so I think the question, this antagonist versus agonist question, remains to be answered. There is some work in the pipelines, and we'll see, what comes of it. But it'll be a challenging piece of research to do. I hope we get the answers in a few years, but we'll see. As Tia alluded to, I think that we need to pay attention to cardiovascular risk irrespective. But the question is, how are we going to do that? And so a couple of big studies that we're involved with. So, and Tia is collaborating with us on one of these called Radical PC2. We're actually doing a pragmatic trial to see whether a routine referral of folks with prostate cancer to see a cardiologist is something that's worth doing. So pragmatic in that sense. And basically, we've randomized over 1,700 men with prostate cancer to either see a cardiologist or have their usual physician's care only, with or without a cardiologist as needed. And so we hope to recruit certainly well over 2,000 people into this trial. It's an international trial, and we expect the results will be available in about 2025. Is it practical for cardiologists to see all men with prostate cancer? Like I said earlier on, I'm not sure that it is. Certainly not in my practice. I don't think I could actually physically do that. And so we're thinking about innovative ways of approaching the problem. One strategy we're developing is in collaboration with the University of Pennsylvania, where we're developing an app that the patient themselves or their families or their healthcare providers could register them for. They can enter some simple cardiovascular parameters, risk parameters, and this could be done online on existing tools. But the real benefit of this particular tool is it will incorporate some information about their prostate cancer, firstly. And secondly, we want to give them some tailored feedback so that they're not confronted by the whole World Wide Web of information about what they could do. They're given some information that is relevant to their cardiovascular risk factors and their level of risk. And hopefully that can be a complementary way to try and provide education and provide a better cardiovascular care for these patients.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email director-icos@gmail.com for more information.
And Arjun, what do you think? I mean, what is your experience with, patients with prostate cancer? I mean, are you only contacted when there's a serious cardiac issue, or where does your practice end up?
Yeah, I think it's pretty similar. And we've had a lot of local discussions as to what is the role of the oncologist in terms of screening, what is the role of the primary care physician, and what is the role of the cardiologist. And I think, as Darryl alluded to, it probably isn't practical for the cardiologist to be seeing all of these patients. And what does need to happen is better screening. And in the UK, the primary care physician is entrusted with carrying out this screening depending upon age. So similar to what you said, Dan, a lot of these patients at their age, male, elderly, do have risk factors and actually are on some form of therapy. And that can sometimes, start before the prostate cancer treatment. And that's obviously great. But there are still some patients, who don't have screening, and they probably, as a community of doctors as a whole, we're probably doing them a disservice by not doing that. But it does remain a challenge. And I think that I do kind of come back to the point that Tia raised, that I don't know how practical it is to expect an oncologist to go through detailed cardiovascular screening when they need to consent the patient for their oncology treatment. And the patient quite rightly has a number of questions much more related to, their oncology, their disease, and their prognosis and their treatment. So really maybe, a more refined screening of, just the history. Do they have cardiovascular risk factors? And just managing them is a good place to start. And if we can get that message out to the community, I think that's really a good thing.
Yes. I'm sorry, Dan. I was just going to throw in a quick fact we haven't really talked about, but another thing as a clinician, I mean, we think about cardiovascular disease, hopefully, but the other thing, at least when it comes to prostate cancer and hormone therapy, I also am trying to understand their metabolic status. I mean, do they have diabetes? And if I'm going to start ADT, am I going to cause havoc with that? Because sometimes I will, just like with having things optimized with the cardiologist, I'll want whoever's taking care of their diabetes, whether it's a primary care or endocrinologist, to see that person beforehand and say, hey, this guy is going to be at risk for his diabetes going cuckoo. And then, because that doesn't really help the cardiovascular either. So that was just my point on that.
Yeah. So I think, one thing, and I've talked to Darryl about this before, so maybe I'll put him on the spot and see what his opinion is. But the Prosper study that was published a year or two ago, major study looking at, I think, I don't remember the drugs, but one of them was enzalutamide, I believe. And in any case, it was enzalutamide plus ADT versus just ADT by itself. And when they did a big study, and this was complex prostate cancer that had already gotten past initial diagnosis, and they found that the people that were on enzalutamide had a improvement in overall survival that was pretty significant I think it was at about 5 years. I'm not sure if it was the right time interval, but nonetheless, when you looked at the adverse events, the group that were treated with enzalutamide had much higher cardiovascular adverse events, and if you added them all up, it was twice as common that they would have cardiovascular adverse events. Now, they didn't die from them, but they had them. And, I think in those situations, if cardiologists or certainly internists or primary care doctors that were in tune with management of cardiovascular disease, that, you could really make a big difference in those treatment arms if you prevented or minimized those cardiovascular adverse events. So, Darryl, what do you think about that?
Yeah, and Dan, we're going to only see more of these patients on these drugs because the field is, and Tia obviously could speak to this with much more expertise than me, but increasingly these drugs, the ARATs, are being tested, evaluated in patients with earlier and earlier stages of disease. So I anticipate that we're going to see a lot of these patients. And as you also said correctly before, Tia, the adverse metabolic effects of the ARATs are on top of any adverse metabolic effects of the agonists or antagonists, or the so-called ADT, if you like. And so I think we need to pay close attention, clearly, to these cardiometabolic effects. And really, I think that's where we can make a difference to enable patients to stay on these drugs safely for as long as they need to.
So, Tia, what things are you excited about in the world of prostate cancer and clinical research? What kind of things do you see coming down the pipeline?
Well, I think so. If you're just talking prostate cancer, not necessarily cardio-oncology, but I think I'm very excited about the immunotherapies. And actually, that's something in the guideline that we didn't have a chance to touch on. But, as in many other kinds of cancer, immunotherapy is becoming a very important component for many patients. But yet these immunotherapy drugs also have their own toxicities. And I was interested to see about the myocarditis section of the guideline, because I actually had a patient die from that. At least I'm 100% convinced that's what it was, even though it was quite late. But then I saw those papers were only recently published showing how late it could actually come on. But I had a lot of pushback from the company about whether or not it was a really, drug-related myocarditis. Yeah,
so this is like the favorite topic of all for ICOS. So, I mean, you can't talk about cardio-oncology without bringing up the concept of immune checkpoint inhibitors. So I think that this is a huge area. Obviously, it's a super important area for cancer. And, so many kinds of cancer are being treated with these drugs. And then, of course, there are potentially serious cardiovascular issues, but, we're trying our best to raise awareness, but also to figure out ways to minimize that. So, Darryl, I mean, what would you say about that? I know you're quite familiar with that space.
Yeah, look, I think it's all that's hugely important as a drug class and as a class of adverse effects. And I think the bigger picture and what's really exciting for me is that we're learning to do research and to treat patients with multimorbidity, with complex disease, and with physical frailty. And that's really a testament to the fact that folks are living long enough and living with diseases long enough that this can be a thing. I think maybe 20, 30 years ago, this wasn't so much of a thing. And most of the trials we have to guide management were really based on single disease populations, so-called clean populations. And we're just not seeing that anymore. So I think our research has to move accordingly to help us understand what the best advice is when you're confronted by a patient with, multiple morbidities, contemplating either invasive cardiovascular treatments or new cancer treatments. Is it really in their best interest? What is the toxicities of their other treatments? How is it going to interact? All these are really big questions. And tied into that is physical frailty, which I think is really important. So I think that's where, we have got, an interest in doing research, and I think where the field's got to move to.
Well, Darryl and Tia, thank you so much for sharing your time with us, but more importantly, your expertise. I know it's a great help to our community, and we really appreciate you being with us today. Thanks so much.
Yeah,
thank you all. Really great discussion.
Good.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.